reason I'm here is to talk to you about Usher, and Usher is kind of a baby of mine that was born a couple of years ago, and it came to fruition because, as you'll see in a second, our pathways are becoming more and more complicated, and our patients are struggling to understand all the information we're hitting them with all the time, and keep hitting them with paper doesn't really help. Our patient population in bariatrics as well has a psychopathology rate of about 70%. So actually we need to work much harder to communicate for them to understand the complex things that we are proposing that they should have. So I'm sure all of you understand that obesity is a problem in the UK and across the world. It's a huge financial burden as well as a physiological burden. And bariatric surgery has been in the news for a lot of good things, but also a lot of bad things, unfortunately, because of complications. But with the advent of the National Bariatric Surgical Registry, we can prove that in high-volume units, it is safe. It's safer to have a gastric bypass in our unit than to have a lap chole in certain hospitals around the country. So the bariatric pathway actually starts from the time that the GP refers a patient for obesity management. Now, that might be for surgery. That might be not for surgery, and with the current changes in commissioning, with the CCGs and NHS England, which I'm sure some of your colleagues here are struggling with, and the devolution of funding from April the 1st, 2016, bariatric surgery from a Tier 4 perspective will be funded again in the community, which primary care are going to have to struggle with. But because it's complicated from the pathway perspectives, the main people that struggle with it are actually our patients, and secondly, the team that has to provide the support for them to navigate their way through the pathway. So the image I've got on here is actually the final image of us creating the pathway on someone's iPhone so they can book their appointment, understand where they are in the pathway, when they were referred by the GP, what investigations are left, what pre-assessments are left, when should they have their surgery, and as you'll see, what to do afterwards. Now, patients are expected to integrate into this team and understand all this information we give them, you know, the complexity of the surgery, the complexity of the pathway, and because we work in it every day, I think we took for granted, and I certainly took for granted, that if you tell something to someone, they'll remember it, but quite obviously that is not the case. So you need reinforcement, and you need reinforcement in a way that people are willing to engage with you. So there's a lot of interest in M-Health. M-Health seems to be, bundled around in terms in journals, talks. But I think the real power of M-Health is actually to allow people to reiterate, reinforce things at a time that is suitable for them. That might be on the tube, that might be on the loo, that might be in the car, wherever you want. And that's what we wanted to create, was a bespoke package for our patients. And that's where the Usher concept was conceived, to develop a smartphone-based platform to provide patient support and basically to be able to put a good bariatric coordinator in the pocket of each one of our patients. The way we started it first was because the reason we started it the way that I'm going to describe in this slide is actually to get the engagement of the hospital, the patients, and the team. So I didn't feel that there's any point building an app in the way that I thought it should be built. At the end of the day, it's for the patients and it's for the team. So actually we integrated that into the construction of the app. And the most important thing right from the beginning was we went to IT at our hospital to make sure that anything that we do is signed off by them, so that when the app comes to fruition, it will eventually be integratable into the world of NHS IT, which I'm sure all of you know can be quite a painful process. So at the time, I had 7 BSc students, and we had a very good link with the business school. So actually, we put the 7 BSc students together to do a business management BSc with regards to how to develop this product. And they were the first people that went off and actually spoke to the patient, spoke to the team, gathered the information to then be able to create what you're going to see in a second. So there was an observational study and a semi-structured interview, and the observational study focused on our patient group seminar and also the one-stop clinic. So in bariatrics, all the patients before they see a surgeon or any other clinician come to a group session, they get given a talk, they get given leaflets, they have their blood tests, ECGs, and then by the time they see myself or Krishna, they've already had the talk, they should understand a bit more about the process, hopefully, and then when they talk to us about the surgery, we should be able to describe some of the things and they ask much more relevant questions. And I'm sure Krishna will tell you, that's still very challenging despite the group session. So how can we get more information across from the group session onwards? The second thing was the interview study, where basically patients and someone from every single part of the pathway was interviewed with regards to what they felt they needed for this particular tool. And what we found were that a lot of things were given on paper, people still not understanding their diet, understanding the process, the complications, the pathway, and actually we hardly used technology. And with all of us using so much technology, our patients weren't really getting that buy-in. So that's why we then started on a journey of building animations that would be useful for adolescents and adults to understand what the procedures were. And I'll show one of them to you at the end of this talk. So this is from our senior bariatric clinical nurse specialist. A lot of patients walk away and absolutely have no idea what they're having regarding their operation. At the time of surgery, they still seem unsure as to what they have signed up for. And I can tell you, with regards to the pre-operative diet, that certainly is the case, because we did a questionnaire study last year on the day of surgery to say, what should you have tonight to eat? And people were still saying something, and quite clear they didn't understand they should only be on clear liquids or nil by mouth. So just little things like that allow surgeons like us to understand that we're not getting our information across as well as we could have. So this was the interview study. So we found that the areas of difficulty were essentially up here. So time constraints, variable individual patient needs. So there is a language issue and a cultural issue. So for example, for me to tell someone who is of Arabic origin, have a high protein, low carb, high fluid diet with this much nitrogen balance and this much, then it doesn't make any sense. So we have to actually sit down with the relevant dietitians and have something that's convertible into the relevant language to be able to say, actually, don't eat baklava, okay? If you're having hummus, don't have this much bread with it. And you need someone to break that down for the patients, and that's something that this journey allowed us to do. Engage with the patients. So we actually found out that 98% of our patients had smartphones. So it's definitely usable in our patient cohort because they're young and they like using their smartphones. Accessibility, language we've talked about, multimedia simulation, and also testing, and we'll see that in a second, and consistency. So we have to be consistent about the information we provide. We're now part of a huge randomized study called the bi-band sleeve study, where all of us have all of our consultations recorded. I don't know how Krishna feels, but when you first start doing this, it's quite arduous because you have to show equipoise in describing every single procedure that you do. So I've learned a lot from that, and those kind of things also help consistency and reliability. So this is Usher, and Usher is a digital support platform across lots of pathways. We've done it in bariatrics. It's now going to be tested in our clinical unit. We've done it in diabetes. There's interest in cancer pathways. There's interest in trauma and orthopedics pathways as well. So it's a collaborative approach developed by the surgeons, the teams. We've got some behavioral scientists that work with me and some designers. And the designers that work with me on this in particular, they're excellent, and they came from the Royal College of Art, which is why everything looks so lovely, because I'm not a very creative person. It's all about the user, and all of it's underpinned by the work that we've done to build it and then test it. And this is what it looks like. So it welcomes you. It plays videos and allows you to access the whole pathway. So this apparently is what I was supposed to look like as a registrar, according to the animators. It welcomes you to our unit, takes you through the doors. I did a walkthrough of our whole pathway. I was videoed, and then they created it into an animation. Takes you to the Discover platform, tells you about healthy living. You have a diary, there's a pathway, how to contact us. And every single step of the way, as you go along, we've actually built a little test. So every time you get some information, you can then test yourself. And those test marks are fed back to the patients, to the team, to see how often you're engaging, because whether you're turning up and listening makes a big difference. They have access to all the animations on the app, so they can watch it as many times. We've made it very simple. It talks about food, hunger, non-surgical terms, and putting it in statistics into terms that they can visualize as well, because that's one of the things they said was a real problem, was that when we say there is a 0.5% of this complication, they don't really understand what that means. As you go along from the healthy living pathway as well, you can actually contact the dietitian, the exercise therapists, the psychologists, etc. You can social network with other patients who are having surgery if they've decided to go online. That's the test, so it's very simple things. They go through it, yes, no answers. And it allows us to understand engagement. And then they have a diary where the gyroscope within the iPhone is integrated into data capture, so they can understand how much calories they're burning. They take pictures of the portion sizes they're taking and upload them, and we understand how much they're taking in. And then eventually they can book their appointment. That's not available yet because of our friend Cerner. I don't know if you have Cerner here. Cerner, the next generation of pain. Okay, so then they can book their appointment, they can see where they are in their pathway, and they can decide what is left and what is not left. But most importantly, I can see the back end. So I can see, when do they log on? Are they looking at the animation? And it basically gives us a score at the back end for the coordinator to be able to, hopefully at the end of the day, tell us in the MDT there is a score of X out of 20 from an engagement perspective and turning up perspective and using the app perspective. That's what it kind of looks like. So we've got the OK to clinically evaluate this. It's been presented at our bariatric research meeting, and there's going to be a randomized study with regards to a group of patients using it and a group of patients not using it. And I'm sure we will let everyone know what our results are. So far, our feedback has been excellent. I actually keep the app on my phone because I'm allowed to download it, and I use it in clinic to see what other feedback I can get. And before I take any questions, just want to thank NIHR BRC for some of the initial funding that we had, all the BSc students, Mo, who's my fellow, Dom, who was my fellow and is now working for Google, and the Royal College of Art, and Ara, who's been very supportive along the way. Thank you very much.